So good evening, everyone, and thank you for joining the joint collaboration between the Wits Students Bioethics Society as well as the Wits Students Physician Society. So I'm Prevan Ramya, the current chair of the Bioethics Society, and I'm very pleased to welcome each and every one of you to the very topical discussion around vaccine mandates. However, before I jump into the hot topic, I just want to congratulate all of the students across our faculty that have successfully completed their academic year. And if the results were less than favorable, to remind all those students that failure really doesn't mean the end of the world. My apologies for that. I had my YouTube opened concurrently. But like I was saying, I just want to congratulate all of the students across the faculty that have successfully completed their academic years. And if their results were less than favorable, to remind those students that failure really only means that you just need a little bit more time in becoming competent in saving human lives. And two digits doesn't really define your worth in the health profession, because learning is a dynamic process. I also just want to share a very pertinent quote that has motivated me throughout this year. And that quote is by Sir Lewis Hamilton, which says that concentration and mental toughness are really the margins of victory. Today being the 1st of December, we know that it's World AIDS Day, and the United Nations have declared the theme for this year as ending pandemics. And in the early 2000s towards the mid 2000s, we've seen that HIV denialism in South Africa was vastly led by fear, stigma, and the need to politicize the virus. And this came at the cost of millions of lives. So let's learn from all of the mistakes that we've made during this AIDS denialism. Let us learn from these mistakes on how to fight the COVID-19 pandemic with science and medicine. While I'm on the topic of HIV and World AIDS Day, we know that HIV is treated with ARVs, and this one pill, in my opinion, is as good as the cure. This one pill can result in undetectable equals untransmissible, prevention of mother-to-child transmission, prevention of progression to HIV. The government has now implemented test and treat, and surely these pills will end the pandemic. So now on to the hot topic and the reason that we all are here today. And enforcing a compulsory or mandatory vaccine against the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 that causes COVID-19 or coronavirus disease across the university requires significant input from the perspective of biomedical ethics and health law. And when we're taking that perspective of biomedical ethics and health law, we need to employ the no-harm principle, which vastly encompasses all four of the bioethical principles, such as autonomy, beneficence, non-maleficence, and justice. And this principle states that the only purpose for which a power can be rightfully exercised over any member of a civilized community against his or her will is to prevent the harm to others. And this principle highlights the need to restrain that right to liberty for the greater public health benefit. There are several instances across the globe where the limitation to the right to liberty has no benefit, is undeniably violates bodily autonomy, such as we look at Uzbekistan, we look at the forced digital rectal examination that only serve to stigmatize the LGBT community, or the forced sterilization of the intellectually unfit females in the state of Indiana. There's substantial evidence that lacks public health benefit, and therefore the state has no legally acceptable right to impose this restriction on the right to freedom or security of the person. At the Bioethics Society, we stand firmly in the belief that the state nor any authority should have this absolute control over bodily autonomy, liberty, and security of the person. However, this liberty, which is the greatest right secured by the Constitution to every person within this jurisdiction, does not import this absolute right to be in at all times and all circumstances wholly free from this restraint. There are manifold restraints to which every person must be necessarily subjected to for the common good. Society based on the rule that each one is a law unto himself or herself would soon be confronted with disorder and anarchy. So the fundamental principle that persons and property are subject to all kinds of restraints and burdens in order to secure the general comfort, health, and prosperity of the state must be vastly understood. So also, while I conclude this introduction and welcome, I just want to share a very interesting quote by one of the great superheroes in the DC universe, which is by Barry Allen, or the Flash. And he says that it doesn't matter if you're the slowest kid in gym class or the fastest man alive, everyone is running, and running means being alive, running from something, running to something or someone. No matter how fast you are, there are just things that you can't outrun. And from this quote, let us run this race together. Let us do this race together. Let us fight this pandemic together so that we can live the life that we lived pre-COVID-19. I'll now hand you over to my colleague, the chair of the Wits Physician Society, that will address us from his side.
Good evening to everyone joining us tonight for this exciting webinar. My name is Marcel Blichnoot, and I am the current chairperson of the Wits Students Physician Society. First, I want to extend my thanks to the Wits Bioethics Society for proposing this very important webinar and for inviting the Wits Students Physician Society to co-host with them. I also want to extend gratitude to our two speakers tonight, Professor Mahdi and Mr. Karodia, for taking time out of their busy schedules to share their expertise with the Wits and greater community. Just to give a brief overview of how this webinar will run, Professor Mahdi and Mr. Karodia will give their expert addresses before we move on to a Q&A session. For those who have questions as the webinar proceeds, besides those submitted with the RSVP form, you can put them in the chat on YouTube, and we will try our best to have them answered. I hope that everyone joining us tonight will gain something from this webinar that hopefully addresses their concerns and or questions. And without further ado, I will hand over back to Previn to introduce our first speaker.
Good evening, everyone. My name is Bride Manukwi. I am the Vice Chairperson of the Wits Students Bioethics Society. And tonight it's my honor to introduce our keynote speaker, Professor Shabir Mahdi. He is the Dean of the Faculty of Health Sciences at the University of Witwatersrand, Johannesburg, and a Professor of Vaccinology. Most of us would know him from seeing him on TV at the talks that he's given on COVID-19. He is also the Director of Vaccines and Infectious Diseases Analytics Research Unit, or WITS-FIDA. He's a co-director of the African Leadership in Vaccinology Expertise, ALIVE. Without further ado, I would like to ask Prof. Mahdi to take the stage.
Thank you, Vera. And could I ask you just to allow me to share my presentation? So good evening to everyone, and thanks for this invite to chat to you once again. And I do realize that based on the feedback I got from Praveen, there's quite a diverse group of students that have selected or decided to join this particular webinar. So what I'm going to do is I'm going to try to keep the scientific content of the talk as light as possible. I know that you are now finished with your exams, and you obviously have had enough for the year when it comes to science and academia. So I'll try to keep it as light as possible, but just try to highlight some of the key issues which are topical right now. And in the context of our institution, obviously, and globally, it's the whole issue of the Omicron variant and what we can expect to occur in South Africa as well as elsewhere in the world. So I'll just touch on that briefly. And then I'm going to spend a bit more time on trying to make the case, or rather trying to explain, not even make the case, trying to explain why mandatory vaccination is simply not an option, and more so for institutions such as Wits. And it's not just about individual choice and individual protection. It goes way beyond that, and I'll come to that towards the end of the presentation. When we look at COVID-19 vaccines, this has been a spectacular success of science in that 2 years since the discovery of the virus, we now have got close to 23 vaccines that are being used in one country or another that's authorized for use. Usually it takes up to 10 years for vaccines to be developed, but because of the amount of resources that were invested, both capital as well as human resources, and pretty much most scientists that are involved in the field of immunology and vaccinology gravitating to focus just on COVID-19 vaccines, we've got a number of vaccines that have already been authorized for use. But at the same time, as we all know, there's a huge inequity in access to vaccines and distribution of vaccines. Where in most low-income countries, and particularly those on the African continent, less than 5% of the population have been vaccinated, compared with growth greater than 80 to 90% of the adult population have been vaccinated in most high-income countries. In South Africa right now, we've administered 25 million doses of the vaccine, of whom about 9.5 million of people are adequately vaccinated, and that is they've received at least 2 doses of one vaccine. And we still got close on to 40 million people in South Africa that have not yet received even a single dose of vaccine. But unlike other African countries, the issue in South Africa is not one of vaccine supply or security of access. That has been dealt with even though belatedly. But the issue now is one of stagnation in terms of being able to ramp up the rollout of vaccines. So right now, in addition to the 25 million doses that have been administered, we've got 17 million doses of vaccine that is lying in a depot in South Africa, which probably will expire sometime towards the first quarter, second quarter of last year. And that is obviously unacceptable given where we are currently and what we're likely to continue experiencing over the course of the next year or two even. So again, I'm going to keep it as light as possible, but for people to really understand what vaccines are all about and what we can expect and to sort of deal with some of the misinformation that transpires in what seems to be the main source of media, of information for most students, and that is social media rather than journals and scientific textbooks. We need to be clear that social media does not necessarily circulate what is scientifically proven, and certainly doesn't necessarily circulate what is really the case of COVID-19 vaccines, the pandemic, or even the virus. Even to this day, we got people that still propagate that SARS-CoV-2 COVID-19 is no different than influenza in terms of the severity of illness which it causes. Which, if it was the case, in South Africa, we wouldn't have experienced closer to 250,000 people dying already from COVID-19. It's not 90,000 people that has been recorded officially. It's 250,000 people that have died, in addition to which millions of others have been infected, and millions of others, unfortunately, have been hospitalized and have gone on to develop long COVID, which is where you get the symptoms of COVID for more than 4 to 6 weeks. So what do we know about vaccines? And when a person is infected with the virus, what we want vaccines to do is to some extent mimic what occurs with natural infection, but doing so without causing harm to the individual or minimizing the harm. If you wait for people to be infected before they develop immunity, you can wait for that to happen. But like I said, already in South Africa, it's caused 250,000 lives to be lost. It's caused millions of people ending up being infected with the virus, in addition to which it's pretty much destroyed our economy. And that is something that should be really at the forefront of the minds of students, where we're currently sitting at unemployment rates of officially at 34%, probably closer to 45 to 50%, and it mainly affects students and people in the age group of students. So when you get onto the job market, unfortunately, in the next 2 to 3 years, it's going to be a tough ride, despite qualifications that you have. So unless we do what is necessary to bring this virus under control in South Africa and elsewhere in the world, we're going to continue facing restrictions. We're going to continue having higher further damage to our economy. We're going to have further decline in terms of job opportunities. And eventually, the people that lose are not those that have made an individual choice not to be vaccinated, but it's the whole of society that suffers. So when looking at vaccines, they really are aimed at inducing 2 parts of what we call adaptive immune system, and that is the B cell responses and the T cell responses. When we talk of B cell responses, these are white cells that produce what we call antibodies. And those antibodies are especially important in terms of binding to the virus, which prevents the virus from binding to the human cells and consequently infecting the human cells. In addition to which those B cells can also play a role in getting the virus to be destroyed. But once the virus is in the cell, remember, a virus is not a living organism. So for the virus to be able to replicate, it needs to make use of the cell machinery. And once the virus is in the cell, if you've got what we call cytotoxic T cells or natural killer cells, they will go on to destroy those infected cells. And once those cells are destroyed and the virus particles are released, if there aren't any cells that they can infect, essentially what it means is that the virus is unable to replicate and unable to cause further harm in the individual. And also the person is no longer able to shed live virus because there's no replication taking place. Now, this is what vaccines do. But in addition to this, what also happens is vaccines also, as well as natural infection, also induces what we call long-term memory cells, both B cells and T cells. So over time, this antibody is expected to decay unless a person is continuously exposed to the antigen that's stimulating this antibody production. You get this decay over time. But unlike in a person that hasn't been previously exposed to the virus or to a vaccine, when you are re-exposed and you've been previously vaccinated or infected with the virus, these memory cells kick in much more rapidly over a short period of 2 to 3 days. And hence they're able to much more rapidly contain the replication of the virus and prevent infection and damage of tissue. So these memory cells is something that we don't usually measure because it's very difficult to measure. But the studies have clearly demonstrated that these memory cells for SARS-CoV-2 probably last for 9 months, probably 12 months, and probably even longer. It's just that the virus hasn't been around long enough for us to understand just how long these memory cells last. But for other viruses, the cousins of SARS-CoV-2, as an example, MERS and SARS-CoV-1, these memory cells have been found to last for up to 6 years. So it's really important to understand that and keep that at the back of your mind. And antibody, unfortunately, its ability to attach to the virus can change over time, particularly when there's a new mutation, when there's mutations that arise, which makes the spike protein less recognizable to the antibody that's been produced by the B cells. And that is what we'll also talk about. So as I mentioned, the virus has mutated, and in addition to the variants that have come to the fore and have got official names using the Greek alphabet, and now we know we're at Omicron, in addition to those, there's been thousands of other mutations that have occurred in the virus that have gone by relatively unnoticed. So mutations is something that occurs all the time. The reason for those mutations is because of errors of reading of the genome during the replication process. But most of these mutations are not clinically relevant in that they don't make the virus more transmissible, or they don't reduce the sensitivity of the virus to the neutralizing antibody activity. So when we refer to a variant of interest or a variant of concern, we're really referring to virus which is now become more transmissible or is able to resist antibody that's been induced either by past infection or by vaccines. So those are terms as variants of concern. Now, what we know about the current variant, the Omicron variant, is that, before I go to that, now the relevance of these mutations, like I said, would differ. For mutations that are taking place involving the spike protein, where those epitopes against the parts of the spike protein against which the antibody is targeted, if there are mutations taking place and those mutations are significantly different from what was in our original virus, then we expect the antibody to work less well against that particular type of variant. But at the same time, remember, I told you there's another arm of the immune system known as T-cell immunity. And that T-cell immunity seems to be relatively unaffected because it sort of targets multiple additional parts of the spike protein. And also for people that are infected, it would also target, the T-cell responses will also be targeted at other components of the virus other than the spike protein, the N protein, the M protein. But the important thing is that when a variant arises, depending the extent to which it has moved away from the Wuhan strain, the original virus that was circulating, that will determine to what extent the virus will be able to escape antibody activity. But when I talk of escape antibody activity, it's not either or. There's a gradient of change in terms of the sensitivity of the variants to antibody activity, and there's also differences between the vaccines. So some vaccines will still maintain high levels of antibody activity against even a variant such as a beta variant, which has drifted quite apart from the Wuhan strain, whereas other vaccines, because of the concentration of antibody that they're inducing, there's very little antibody activity left to basically tackle a variant such as a beta variant. Now, with the Omicron variant, which is not on the slide, we expect it to have even drifted further away than the beta variant compared with the Wuhan strain. So we expect antibody activity that's been induced by past infection, as well as by past infection, as well as by vaccination. That antibody activity will be lower against against the Omicron variant compared to the Wuhan strain. But what's important to understand is that that doesn't mean vaccines won't work, and that doesn't mean vaccines won't protect against infection, and that doesn't mean that vaccines won't reduce the likelihood of people that are infected, that have a breakthrough infection after being vaccinated, being less likely to transmit the virus. And I'll show you some of this evidence for the Beta variant. Like I said, the virus has continued evolving, and this is unsurprising. We expect RNA viruses to be mutating all the time. In fact, when you see influenza virus, which causes about 10 to 11,000 people to die each year in South Africa, the mutations that take place in influenza virus is much greater than the rate of mutation that's taking place with SARS-CoV-2. But we don't see the same sort of surge of cases, of severe cases and deaths from influenza. And the reason for that is that over time we have developed immunity against influenza. A very multifaceted immune response has taken place in a majority of individuals, which even when you have these mutations, which might make the virus a bit more resistant to the antibody that was induced in the past, simply because of other components of the immune system, you don't have these severe outbreaks, of severe disease for influenza. So influenza mutates much more than SARS-CoV-2, but we've got sort of a built-in immunity that has evolved over time that protects us even against infection and severe disease. So what we saw happen in South Africa is that initially until around about August, September of last year, it was mainly dominated by the ancestry virus, and subsequent to that, as we all know, exactly about a year ago, there was identification of the Beta variant, which very much dominated during the course of the second wave. But around about April, May of this year, eventually what happened is that we had a Delta variant that started to emerge in South Africa. The Delta variant initially was identified in India, and very soon the Delta variant outcompeted the Beta variant. Now, in between all of this, there was another variant known as C12, which most of you probably haven't heard of, which was sort of a chimeric, a combination of the Beta and the Delta variant. And there was a point in time when scientists, people that are doing sequencing, were concerned that this could become a big problem in South Africa. But what you see happening is that the C12 variant essentially disappeared from the radar very much fizzled out, wasn't able to compete with the Delta variant. And now most recently, we've got an Omicron variant, which has arisen. And initially right now, the epicenter where most of the cases are occurring is in Gauteng. More than 90% of all of the cases that are being reported are in Gauteng, and the majority of those, although not all of them are sequenced, we only sequence a fraction of all of the cases that do transpire that are diagnosed, and we only diagnose a fraction of all of the cases that are actually occurring. But of those cases that have been sequenced, the majority right now is the Omicron variant. So even though you see the steep increase in the Omicron variant, that doesn't necessarily mean that it's going to outcompete the Delta variant. It's only over the next 3 to 4 weeks that we'll be able to tell whether the Omicron variant is fit enough to outcompete the Delta variant. And then there's a number of other questions about the Omicron variant. Now, why is this variant of such sort of headline news around the world? And the reason for that is that this variant has got multiple mutations, including mutations that were initially found in a Delta variant, in the Alpha, in the Beta variant. But in addition to that, it's got other mutations, which are unique mutations. And those unique mutations putatively would suggest, or rather, those additional mutations would suggest theoretically that this variant could become resistant to antibody activity that was induced by vaccines, as well as antibody that's been induced by past infection. But again, important to emphasize, when I'm saying relatively resistant, it doesn't mean it's all or none. We still expect, or at least I still expect, that depending on the magnitude of antibody responses that's been induced, that some vaccines would perform still in protecting against infection and mild COVID due to this variant. Perhaps not as well as they performed against the Beta variant or the Delta variant, but we will still get protection. In addition to which, like I emphasize over and over again, it's not only about antibody, it's also about T-cell immunity. And those T-cell immunities with this particular variant, again, based on what the mutations map out on the genome, some of the T-cell responses would be affected, but not all. And in fact, it's just a minority of the T-cell responses that are likely to be affected by this mutation. So I think we will still get relative preservation of T-cell responses. So to put all of this together, what can we expect with the Omicron variant? Firstly, it's too early to tell what's going to happen next. Like I said, from a theoretical basis, we can expect that antibody activity will be diminished, but those data need to be supported from laboratory studies that are currently underway, and we probably will get an answer in 1 to 2 weeks whether antibody activity is less effective in neutralizing the virus, both in people that were vaccinated or people that have recovered from past infection. So that's the first thing that we need to do. We need to see if there's a clinical relevance to these mutations, which means we need to, over time, over the next 2 to 3 weeks, figure out whether this virus is more transmissible than even a Delta variant. And then the other part of the clinical relevance is what we are already seeing is a number of breakthrough infections, people that are vaccinated getting infected, which is not surprising, given that we do expect there to be lower neutralizing antibody activity against the variant. But in addition to that, we're also seeing that people that have previously been infected to the virus, who have not been vaccinated, are also getting reinfections. Now, the next big question is most of the infections that are currently occurring is occurring in relatively young people, and very little of it is ending up in severe disease. But the big question is we can expect an increase in the number of people that are infected with the virus during the course of this wave compared with what we experienced with the first 3 waves. So I wouldn't be very surprised if the numbers of cases that are being diagnosed on a daily basis goes 25, 30, 40,000 even in South Africa. I think that's something that we can well prepare ourselves for, but the unknown is whether those cases are going to materialize into severe disease. And I'm fairly optimistic that despite us probably experiencing larger number of cases that are diagnosed in a community, we're not going to see as severe a number of cases of hospitalization and death compared with what we experienced in the first 3 waves. And the reason for that is that there's been a gradual building up of immunity, at least against severe disease in South Africa. And that is not just from vaccines. Vaccines, unfortunately, has played a very modest role because of the modest uptake of the vaccines, but rather because of in fact, we're doing a serious survey in Gauteng at the moment where we test for antibodies as a measure of past infection. And the serious survey indicates that 72% of people in Gauteng have been infected to the virus during the course of the first 3 waves. And that doesn't differ by age group. And as I mentioned, although this past infection doesn't really produce good antibody responses and is not very sustainable, and people can have reinfections, especially when there's a variant such as the one that has arisen. On the contrary, what happens is that these past infections do induce good T cell responses, which is likely to protect people against severe disease. Now I'm going to go briefly to the issue of herd immunity, and this is the issue of vaccines. So what is herd immunity? So many of us use the word herd immunity very loosely, and the bottom line is that we're never going to get to herd immunity with SARS-CoV-2. To be able to get to herd immunity for this virus, and especially as an example for the Delta variant, what would be required is the type of immunity that that reduces the risk of people that are exposed to the virus being infected by 85%. Or that is at least 85% effective in preventing the transmission of the virus after a person has been exposed to the virus. And there's no vaccine and not even natural infection that comes close to being able to give that sort of protections at this point in time. So with 85% of the population needing to develop that type of immunity that prevents a person where a person is protected against being infected, or even if infected, the person is not going to be able to transmit the virus, with that unlikely scenario, unlikely to materialize anytime soon, we can stop talking of herd immunity. We're not trying to get to herd immunity. And herd immunity by extrapolation would mean that we would eventually be able to eliminate the virus, which is not going to happen. So we need to learn to live with the virus, and that has become the new reality, but doesn't mean that we need to continue living the way we've been living for the past 21 months, because we do have tools available to us to go beyond where we are currently and to actually do what is happening, as an example, in the United Kingdom, where they can afford to have stadiums for soccer matches that are full to capacity of 65,000 people, not wearing any mask. And it's not because they're not experiencing infections. In the United Kingdom right now, each day they have between 40 to 50,000 new cases that are diagnosed. But those new cases are not materializing into hospitalization and death in large numbers. And the reason for that is not because of some miracle of nature, but rather because the vast majority of the people in the United Kingdom have been vaccinated. So even though people are getting infected, they might spread. Firstly, the vaccines do reduce the number of people that are infected. And when you have these breakthrough infections, they're probably less likely to transmit the virus. One of the issues that has been raised previously is that, well, people that have been vaccinated that have a breakthrough infection have as high viral loads compared to unvaccinated people, which is true, both for the alpha variant as well as the delta variant. So when a person is having a breakthrough, but first and foremost, remember, people that are vaccinated are less likely to be infected than unvaccinated people. That's your starting point. But when you have these breakthrough infections, yes, they start off with higher viral loads, but the difference is that people that have been vaccinated, they will have a much more rapid decay in a viral load compared with unvaccinated people, as shown in the pink. And the significance of this is that the more virus that you've got and the longer you're shedding virus, live virus, the more likely you are to transmit the other virus to others in your environment. Now, the reason for this more rapid decay of the viral load in individuals that have been vaccinated is simply because those memory cells have kicked in. Those B cells have kicked in. You're starting to produce an antibody much more quicker than a person that hasn't been previously infected with the virus, and consequently, you're able to bring that virus replication under control. And consequently, you pose less of a risk. I'm not saying you don't pose any risk, but you certainly pose less of a risk of transmitting the virus than an unvaccinated individual that was vaccinated, that was infected. Now, in addition to that, what we also see in vaccinated individuals that have breakthrough infections is that they end up with significantly less severe disease than unvaccinated individuals. And what I haven't shown here is that they're also less likely to develop long COVID if they have a breakthrough infection after being vaccinated compared with someone that is unvaccinated. Now, these are data from the Netherlands. It just came out about a week ago, and it really emphasizes the point about why we're needing to be vaccinating everyone to be able to get back to a relatively normal lifestyle. It's not about eliminating the virus, but what this data basically shows. Firstly, is that an unvaccinated person is about 50 times more. So now, first and foremost, again, remember, vaccinated people to start off with are less likely to be infected with the virus. Even if it's 50% less likely, they're less likely to be infected with the virus. When they have breakthrough cases, unvaccinated people are more likely to transmit to an unvaccinated person than a vaccinated person, which means that if you're unvaccinated and you're exposed to someone that's been unvaccinated, you're more likely to be infected. Compared with someone that's been vaccinated, you're less likely to be infected by an unvaccinated person that's been infected with the virus. But in addition to that, what we see is that people that are fully vaccinated, they're 63% less likely to actually transmit the virus to unvaccinated individuals in the household, and 40% less likely to transmit the virus to other fully vaccinated people in the household. So what it tells us is that vaccination protects against infection, and vaccination reduces the chances of transmitting the virus to your close contacts, whereas unvaccinated individuals are more likely to transmit the virus not just to their unvaccinated contacts, but also to vaccinated contacts. Sorry, just 1 second. So in conclusion, firstly, we need to recalibrate our expectations of the COVID-19 pandemic. Like I mentioned, the virus is not going to disappear anytime soon, if ever during our course of our lifetimes. And we also need to be measured about our expectations of COVID-19 vaccines. These vaccines work extremely well in protecting against severe disease and death, irrespective of which variants have arisen up until now. The vaccines might work more modestly in protecting against infection and breakthrough, but when breakthrough infections do occur in vaccinated individuals, those individuals are less infectious. So what is all of this to sum up in the context of mandatory vaccination? Firstly, I think anyone that chooses not to be vaccinated is being foolish because they're depriving themselves of individual protection against infection. And you might not be too worried about being infected as a student, but at the same time, even mild disease, mild COVID, results in long COVID, where you have residual symptoms that can be long-lasting for up to even 6 months. Long COVID, we mean that symptoms are ongoing for at least 28 days, but some cases have been ongoing for up to 6 months, and if not longer. And there might be other residual effects that are still unknown to us. And as I mentioned, certainly a vaccinated person is much less likely to end up in hospital or to die of COVID. In addition to that, again, I was at pains to point out that vaccination does prevent infection, even if not as good as how well it protects against severe disease. But breakthrough infections in vaccinated individuals, they pose a lower risk of transmitting the virus. Now, that is important, not just for your fellow students who probably won't develop severe disease if they actually end up being infected by you if you're unvaccinated, but it's important for other people in the workspace and in the university who might be fully vaccinated, but they still got underlying medical conditions, which suppresses the immune system, and they're unable to get the optimal protection even against severe disease. And if we have unvaccinated people posing a greater risk than a vaccinated person to that individual that has got underlying high-risk conditions that predisposes them to still developing severe disease despite being vaccinated, that calls into question as to how the institution actually manages the health and safety of everyone in the environment over and above trying to protect the rights of an individual. Now, in addition to that, like I said, what we're also wanting to avoid is overwhelming of healthcare services. And when people choose not to be vaccinated, yes, they can make that personal choice at a point in time. But unfortunately, when they end up needing to go to hospital, they don't make the choice of not going to hospital. They actually make the choice of going to hospital to get oxygen and to drain our healthcare facilities of its resources. So it's being completely selfish to expect to make use of facilities that could otherwise be utilized for other purposes, especially in a country such as South Africa, where healthcare facilities are perpetually stretched to capacity and want to accommodate individuals that have chosen not to be vaccinated but end up in hospital. And right now, the majority of cases that are being hospitalized are people that selfishly decided not to be vaccinated. So yes, it's an individual choice, but it comes with consequences, and not just to yourself, but it comes to consequences to the rest of society when unvaccinated individuals place a disproportionate burden on the scarce resources that are available to us in the country when it comes to healthcare. In addition to which, when we start seeing an increase in hospitalization, primarily driven by unvaccinated individuals, what will happen next is government will go back to higher levels of restriction, and that comes with the consequences of, again, shutting down the economy, and that comes with the consequences of further pushing our economy into the doldrums. That comes with the consequences of less job opportunity for you students again in the years to come. And that comes with the consequences of possible social upheaval. So when we talk about mandatory vaccination, yes, think about it in your own context, but it's not about you. It's about society. And in university, it's about every other student and staff member and every other visitor to the university whose interests are way above the interests of any single individual. So thanks for that opportunity, and happy to take questions.
Oh. Thank you so much, Prof. Shabir. It was so valuable to be listening to an expert in vaccines and infectious diseases and to have a greater understanding of how the SARS-CoV-2 vaccine works. The impact of the pandemic has been devastating and far-reaching. The vaccine is a powerful tool to prevent severe infection and propagation of mutations. It is very important to dispel as much misinformation as possible and to address vaccine hesitancy. Thank you again to Prof. Mahdi for taking the time out of your evening to share your expertise with us. I will now hand over to my colleague, Marcel, who will be introducing our next speaker.
Thank you so much. I am excited to introduce our second guest speaker for the night, who is Mr. Musa Korodia. Mr. Korodia is a lecturer and researcher of clinical pharmacy and pharmacy practice here at Wits' Department of Pharmacy and Pharmacology. He is also the pharmacy manager at the nonprofit Trinity Clinic in Braamfontein, which provides free medical and pharmaceutical services to the homeless. He also serves a leading role in Wits' response to the COVID-19 pandemic as the project manager and responsible pharmacist for the Wits Health Consortium's COVID-19 vaccine site. Mr. Korodia, we are all eager for you to share your expertise, so over to you.
Hi, everybody. Can you hear me?
Yes, you can.
Okay, so anyway, I'm an associate lecturer in the Department of Clinical Pharmacy, Division of Clinical Pharmacy and Division of Pharmacy Practice for the Department of Pharmacy and Pharmacology. And I've been fortunate enough to be the experiential learning coordinator for BPharm 1 up until BPharm 4. So today I'm just speaking to you about the role of pharmacists and other healthcare professionals in vaccinations. And I'm proud to say that when the Banking Association of South Africa approached us together with Wits Health Consortium, we were able to manage to actually run their site completely. It was a completely student run and led vaccination site. However, unfortunately, due to vaccine hesitancy, I noticed the vaccine numbers drop from 900 a day all the way down to 20 a day after 4 months. So the opportunity there that was initially proposed was to vaccinate between 70,000 and 140,000 financial sector employees in the Greater Sandton area. However, we managed to only vaccinate 25,000. And I'm not sure whether that made such a big dent in the vaccination requirements. However, I would have loved to carry on or to proceed in another direction because actually today I read something from Adrian Gore at Discovery that says that 94% of Discovery employees are vaccinated. So I was a bit sad that the banking employees were not, the vaccinations were not made mandatory for them. And we also offered their household members as well as their spouses vaccinations. I was also involved in multi-choice, actually vaccinating their employees, but multi-choice is actually reopening in the next month or two to actually dish out the second dose of the Pfizer vaccine. Because a lot of our patients we found at BASA in Sandton at the FNB Conference Center, we had actually done most first doses and were complete, and we were almost complete with the second doses. We found that there was a lag in first doses. So we are actually in the process of writing a paper, and the information should be in there where you can actually see the drop. So as the rise of second dose vaccinations increases, there's a lag and a drop in first dose infections. Unfortunately, I'm not sure as to whether this can be attributed to health promotion or to much more education. I can blame social media because a lot of the questions we had were untrue and were from social media. The interesting thing is we had a lot of medical students. Actually came in. I had them trained. I had everybody trained with the GCP, which is good clinical practice. I had them trained on how to mix the vaccine. And then I had them do the Knowledge Hub certification in order to complete the vaccination training. And then we did the 15 observations, and then they were allowed to vaccinate. So we were fortunate enough to have a lot of medical students and a lot of pharmacy students, as well as one or two physio and occupational therapy students, as well as auxiliary nurses. So one thing that I'd like to commend our students at Wits on, and the faculty as a whole, this proved to be a very multidisciplinary approach. And I think that's what Wits has been looking for as a faculty of health sciences for quite a while, for interprofessional education. And this was a perfect example of IPE because we also had a medical doctor on site. We had 2 resus rooms, as well as 4 to 6 BLS, basically life support staff members, as well as advanced life support staff members. And our students were able to be given demonstrations on how to operate an AED, how to distinguish what is an adverse event. And then we also did a lot of our curriculum, we incorporated it into the site. For example, I broke it down into how to report an adverse event on the SAPRA reporting app, as well as through the NADMC, and as well as through the company. So for me, we're almost done with the paper, and I'm very excited because I don't know if I can push forward and say this was the first student-run-led vaccination site in the world. But I can say for sure in South Africa and in Africa, we had only students running the vaccination site, and we vaccinated a total of 25,000 people, and I think that's commendable. And I'd like to extend my gratitude to people like Prevan and those members of the Bioethics Society, as well as Prof. Shabir Mahdi and Prof. Chinara, who gave us the opportunity to run with the project. From there were side offshoots where we were sending students off to like the Houghton Mosque site, and then we sent people to sites in Randburg, sites, you know, I actually received a certificate from the MEC for social development, thanking us for training students and then feeding the students back into the DOHS system. I'd like to thank you. That's all I have to say on the matter. And I hope you look forward to receiving our article very soon.
Thank you so much, Mr. Korodia. We really appreciate you sharing your expertise and your experiences so far. Also, on behalf of the Wits community and also the greater public community, thank you so much for what you have done in terms of running the vaccination site here at Wits. There is no doubt that it has made a big contribution to public health and safety, and thank you for training medical and other health sciences students in vaccinating. It is definitely believable. It must be said that the vaccination site here at Wits will make the mandate that Wits is implementing next year much more efficient, so that students do have the opportunity to have easy access to vaccination. And definitely a good point that social media has played a big role in spreading vaccine misinformation. So thank you once again, and I will now hand over to Prevan, who will be starting off the Q&A session.
Thank you, Marcel, for that. And again, thank you to both of our speakers, Professor Mahdi, as well as Mr. Korodia, the very informative presentations. And as you can see, that these are two well-renowned experts in their field. And that is how we need to lead this pandemic. And that is how we need to exit this pandemic, is with the experience of experts in their field. Mr. Korodia and I had the privilege of working together at the vaccine side, and we've learned so much as medical students to really make every effort to exit this pandemic. But moving on to the question and answer session, our first question for today is that the evidence points towards the fact that the virus can still use a person to spread even if the person was vaccinated. We can even see transmissibility with the vaccine. The argument to get vaccinated for the protection of others fails in this regard. I want to make the statement that any institution cannot take away the autonomy of a person when they use this argument, especially addressing this fact. How do you rebut it?
I'm sorry, I didn't get the question.
Sure, Prof. The student is asking that the vaccine doesn't result in a zero transmissibility, so that persons that are vaccinated can still transmit the virus. But while we're using this argument that it helps in protection of greater public health benefit for the vaccine mandate.
I thought I repeated that a few times during the talk. The vaccine doesn't prevent infection, of course. It doesn't prevent infection, or else there wouldn't be any virus in the United States or the United Kingdom, where they vaccinated the majority of the population. But even reducing the transmission of the virus by 50% is better than not reducing the transmission at all. And 50% is better than 0%, just like when you pass. If you get 50% and you pass, and you get 40% and you fail, there's a big difference between the two marks. The one is fail and the one is pass. So basically, even if you're not completely reducing the transmission, vaccinated people are less likely to transmit the virus than unvaccinated people. So unvaccinated people pose a greater risk of transmitting the virus in the environment than vaccinated people. Are you on mute?
Yes, sorry, Prof. So I think that clearly answered the question, as well as that was discussed in your presentation. Marcel, can we have the next question, please?
Hi, yes. Okay, so the next question is, do you believe that a vaccine mandate for healthcare workers is the onus of the healthcare institution to uphold occupational health standards?
Absolutely, without any question. And certainly in the Faculty of Health Sciences, the board basically made a decision that no student will be allowed to rotate to any of the clinical facilities if they're unvaccinated. The hospitals themselves need to take direct responsibility to ensure that healthcare workers, and when I'm talking of healthcare workers, I'm talking of it in its broadest term, anyone that works in a healthcare environment, that they don't pose any risk over and above what a vaccinated person would pose in terms of the transmission of the virus into other people in that environment. In addition to which, when it comes to healthcare workers, when healthcare workers choose not to be vaccinated and they get infected, even if they have mild disease, they need to take 10 days off from work and go into isolation. That places a burden on the other fellow healthcare workers, who then need to cover for them, in addition to which it obviously undermines the ability of us to be able to provide quality healthcare. So when it comes to healthcare workers, it's simply, in my mind, a non-negotiable that all of them should be vaccinated. And if they choose not to be vaccinated, then I think there needs to be some sort of managed parting of ways between the facility and the healthcare worker.
Thank you for that answer, Prof. I think that is a very important point regarding the mandate, specifically in the healthcare context.
So our next question is, what is your view regarding the COVID-19 pills for poorer nations?
I'm sorry, Praveen, you froze there. I couldn't get a question.
Sure, no problem, Prof. The student is asking, what is your view regarding COVID-19 pills for poorer nations?
COVID-19 pills or vaccines?
COVID-19 pills.
Pills. So I suppose they're referring to the antivirals that have made some news over the past few weeks. And certainly, just like vaccines, even antivirals and therapeutics need to be accessible to everyone, irrespective of where in the world they are. But the bottom line is that there are market forces, which is what we always lived with. So antivirals need to become available. But again, antivirals are not there to prevent COVID. Antivirals are there to prevent infection progressing to severe disease. And it only works when it is given at a very early stage of infection, within 2 to 3 days of a person becoming symptomatic, provided the person doesn't have severe disease already. And right now, it's mainly been evaluated in people at high risk of developing COVID. These antivirals are not going to be readily available, and they're going to be extremely costly. So this is not a substitute for vaccines. Vaccines are basically for free in South Africa. We obviously pay for it through our tax money. But otherwise, these antivirals, again, to emphasize, they are not they are not there to prevent COVID. They are there to prevent the progression of infection, people that are already infected, to developing severe disease.
Thank you for that, Prof.
Okay, our next question is, how do we rank the priority of getting 10 to 15-year-old children vaccinated?
Well, we should be, if we got enough vaccine, we should be vaccinating everyone, including children between 10 and 15 years of age, or 12 and 17 years of age, whatever it might be, and probably very soon even between 5 and 12 years. That's if we've got enough vaccine. But right now, the priority in South Africa is not about vaccinating young children that generally just get mild COVID, or usually a majority of children, in fact, are asymptomatic. They won't even know they've been infected with the virus. The priority is to optimize protection against severe disease. So rather than using a single dose of vaccine in the of the Pfizer vaccine in a 12 to 17-year-old, which in fact won't confer any protection against infection and mild COVID due to the Omicron variant, instead of using it for that purpose, we should be using it to boost people above the age of 60 who have already received even 2 doses of the Pfizer vaccine, and certainly any adult that has already received a single dose of the J&J vaccine, that is incomplete vaccination. Adults need to get 2 doses of the J&J vaccine at the minimum. And they might also get a booster dose of the Pfizer vaccine rather than a booster dose of the J&J vaccine. So if we've got enough vaccines, certainly we should be inclusive. But obviously, when we start vaccinating young children, we also need to understand that we're playing a role in terms of contributing to the inequity of access to vaccines for other low-income countries. Because one of the reasons other low-income countries have struggled to gain access to vaccines is because high-income countries, rather than using those precious doses of vaccines to save lives in low-income countries, high-income countries have been hoarding those vaccines, giving it to children, including using booster doses of vaccines in age groups and individuals that are not at high risk of developing severe disease. So these sort of decisions need to be holistic in its approach, rather than just about what is good for South Africa.
Thank you for that very thorough answer, Prof. Previn, next question, please.
Sure, no problem. So the next question is that now that healthcare workers are taking their booster shot, given that they had a choice, which vaccine would you recommend, the Pfizer vaccine or the Johnson & Johnson vaccine?
Well, the choice they need to take is a vaccine that they can get soonest into their arms, especially now that we're going into a resurgence. Had they had a choice, then the clinical data, the evidence clearly shows that a Johnson & Johnson vaccine followed by the Pfizer vaccine induces much more robust neutralizing antibody responses, as well as more robust T-cell responses. And then when it comes to the AstraZeneca followed by the Pfizer, compared with even 2 doses of the Pfizer vaccine, that combination of the non-replicating vector-based vaccines followed by the messenger RNA vaccine, in fact, results in fewer breakthrough cases. So the preferred booster in my mind for people that receive a non-replicating vector-based vaccine would be the Pfizer vaccine. But unfortunately, that option doesn't exist in South Africa. And I think the worst thing that you can do as a healthcare worker is to delay vaccination, waiting for that option, especially now that we are in a 4th wave in Gauteng.
Thank you, Prof.
Okay, so I'm gonna skip the next question because it was about the Omicron variant, and I think you covered that sufficiently in your presentation. So the next question would be, will newer vaccines be engineered for newer variants as they emerge? Will there be an annual event as with flu vaccines?
Yeah, so that's a really good question. And in fact, already in South Africa, we are evaluating a 2nd generation of vaccine that is more inclusive than just targeting the spike protein, which we are quite optimistic that it would probably work better against even Omicron than the current generation of vaccines. In addition to which, many companies are already looking at developing vaccines specifically targeted to the Omicron variant, including Moderna, Pfizer, and possibly even AstraZeneca and others. But those vaccines are unlikely to be available at least for 3 to 4 months in a best case scenario. But work on that is already underway. And obviously the Omicron specific vaccines is work that they just started literally in the past week. Whereas for these other vaccines that I'm referring to, those vaccines were designed as 2nd generation vaccines that target both the S as well as the N protein. And again, those vaccine studies are currently underway in South Africa. When it comes to the booster dose of vaccines, at the end of the day, it will depend on what happens to the virus and how it evolves, and whether it becomes just another nuisance type of a coronavirus, such as the endemic coronaviruses, or alternatively, whether it continues to cause lots of severe disease and in whom it's causing severe disease. So right now, if you ask me to guess what's going to happen over the next 2 to 3 years, which itself is a long period of time in the context of COVID, I do expect that we would need to provide booster doses of vaccines, especially to people with underlying medical conditions that places them at high risk of developing severe disease. And we might need to boost them as much as every 6 to 12 months. But that information will come out in the next few months. But when it comes to healthcare workers, that's a one category of individuals that we're probably going to need to boost annually at least for the next 2 to 3 years until we see exactly what course this virus is taking, whether it becomes an endemic virus, causing just a modest amount of deaths as opposed to what's currently happening. Because for healthcare workers, unlike the general population, where the main focus is around protecting against severe disease, like I mentioned earlier, when it comes to healthcare workers, we're also trying to protect what happens in the environment, including their colleagues as well as their patients and the healthcare system itself. So it might well be that for healthcare workers, we're looking at least at annual vaccination for the next 2 to 3 years.
Thank you for that answer. Prof, I think that addresses a big question that many have of how long will we have to keep getting vaccinated in order to maintain normality. So I will hand back over to Previn now.
Thank you, Marcel. So the next question is, will there be a combined vaccine in a single dose that would cover both the latest flu vaccine as well as the COVID variants each year?
So with flu, it's a bit more difficult because the flu vaccine is adapted each year based on what we predict to be the new mutations that are likely to occur in the virus. Whereas with COVID-19 vaccines, generally we would expect, hopefully, those vaccines to become more stable in that over time we're not going to need to adapt to each variant. There is companies that are looking at combining these two vaccines, if not in the same vaccine as given as two different shots at the same time, as an example. A multivalent vaccine that includes flu as well as COVID-19, that would be a good to have, but that certainly is not the priority right now. The priority right now for flu to start off with is to get better flu vaccines than what currently exists. And the priority for COVID-19 is to see which vaccines can really assist us in preventing severe disease and death. So I think the combined vaccine, it is a theoretical possibility, but unlikely to materialize anytime soon.
Thank you, Prof, for that.
Okay, so I think that is enough Q&A questions. We don't want to keep everyone here too long. So just want to ask you, Prof. Mahdi and Mr. Karodia, if you have any closing remarks. Otherwise, we can conclude.
Yeah, thanks, Marcel. So I mean, just to say, like I mentioned, when we talk of mandatory vaccination and we argue the case of individual rights, we need to understand we don't live in a cocoon or in a bubble, and that can only, that our decision only has consequences on the individual. For everyone else around you that you live with, as well as that you work with, and that you go to university with. So I really find it unfortunate that we had what was transpired at Wits in the past 24 hours with the SRC coming out with a statement, which simply is not factually incorrect to start off with, and really undermines the attempts of the university to try to get back to a relatively normal lifestyle as soon as possible, and to give students a fighting opportunity to be able to complete the studies with minimal amount of disruptions, and to try to secure what remains of our economy so that when they do complete their studies, they've got some job opportunities that will materialize.
Any closing remarks from you, Mr. Karodia?
No, thank you, but I'm glad I got the opportunity to listen to Prof. Shabir Mahdi. It's been very educational. Thank you for inviting me.
Okay, thank you so much. So on behalf of the Bioethics and Physician Societies, we want to extend our large thanks to both you, Prof. Mahdi and Mr. Karodia, for being here tonight and sharing your expertise as leaders in your respective fields, and by addressing the discussion around mandates for healthcare workers and the new Omicron variant. This comes especially in a time where misinformation and uncertainty is rampant, and there is a recognized need for informative and educating engagements between experts and the public. We also want to thank those who have attended this webinar and sent in questions for our speakers. It is our hope that your concerns and questions have been addressed and that you have a better understanding of vaccine mandates for healthcare workers on scientific, moral, and bioethical grounds. We hope to see some of you at our society's events in the future. We hope you all have a good rest of your evenings. Good luck with the rest of the academic year and enjoy the holidays.